Hello, everyone, and welcome to A Girl Like Me Live. This is our 22nd episode, and I'm so excited to be here. A Girl Like Me Live is an interactive live streaming series advancing health and wellness discussions and education among women living with and vulnerable to HIV. So, monthly ICC will sit down with different co hosts to chat about key topics in our community. Today, I have Dr. Theresa Mack, who is a medical editor here at the Well Project. And I'm just the moments I've spoken to you, I feel like you are full of so much knowledge that I'm really excited for you to be able to share today. So I'm just going to ask that you introduce yourself, your affiliations, how did you come to know the Well Project, and we're going to jump right in.
Okay. Hi, my name is Theresa Mack, and Cece said something about a wealth of information, but I think that about her. She did a webinar last week, and I learned a lot of information. And so, my name is Theresa Mack. I'm a primary care physician here in Harlem, Central Harlem. Um, I'm a medical director of the facility, and it's all part of Mount Sinai Hospital Icahn School of Medicine. And I've been an HIV specialist for years, and actually been practicing for over 30 years.
Whoa, that's a long time.
Yeah.
Wow. Okay, so we're here today to talk about patient provider communications. And
Hmm.
this has been a sore spot for me for a while. I think having the opportunity to speak with more providers and to be able to like humanize them instead
Hmm.
of, thinking that they were or that they are a person that is right all the time or that I have to follow their demands, like just changing that dynamic in that relationship myself first has helped me become such a better advocate for myself. Um, Hearing from your standpoint, how important is that the communication between patients and providers?
Oh, Cece, it is huge. I mean, you have to have the communication. And one thing that you said was, you know, are they always going to be right? They have to listen to you. Okay. Remember, you are the patient, you're the physician. It should be a partnership. Partnership is 50-50. I may not agree. You may not agree, and so we'll just show respect and try to figure out what is the common ground. But the most important thing, I think, that the provider and the physician, the provider and the patient relationship, is that they have to have a provider that will listen, and that sometimes can be challenging, but providers went into it to help people. So sometimes, if you're not getting that listening, you may have to say something to them and not be afraid. You have to be your own advocate. Okay. Um, and there was something else that you said that I had wanted to address, and I can't remember, but I think it was along the lines of the treatments and things that we have to do. We may not agree on how to treat the disease, okay, but we have to come to a happy medium. And one of the things that I always have said and I've learned is that I look at guidelines, but I treat the patient. So if a guideline says this is undetectable and then this is U equals U, oh, that's all fine, well, and good. I love it. However, if the patient is undetectable and has a poor quality of life, we have to do some other things so that that patient can have a good quality of life. And I may have to take them off of medicines. So we always talk and say, is it better to have undetectable and you can't do nothing? Your quality of life is terrible. Or is it better to have a viral load and you can do things? Okay, you can be the mommy, you can work. And so we just have to figure it out and see how you could still stay healthy and protect others.
Just the fact that you would consider all those other things that an individual could have going on, like that, undetectable is great. I'm undetectable. I'm grateful, but for some people, I also realize that just won't be their thing. So, like, treating the whole person. It's not just about my viral load.
That's right. It
And
it isn't. And again, all of this, it, I know we're trying to improve provider and patient um, relationships and communications, but the elephant in the room is racism. And so we have to be able to be an advocate for that. And I don't mean that of racism that you could work in a facility and have real nice people. I'm not saying that the racism is the people, it's the policies and things that perpetuate. And that is what we need to address. There is a question that said, "Do you take off all medicines?" Um, it's an individual approach. Sometimes I have to do that because they're going to stop anyway. Okay, if you're not feeling good, they're going to stop anyway. So what you do is you keep them close to you. Okay, they're the people I need to see more often than I see Cece, who's undetectable. So, yes, I have taken them off medicines and I watch them, okay? And I make sure that they are healthy in other ways or that I am preparing them for other ways. I make sure that their vaccinations are up to date, that they don't have high glucose, and if they do, I'm treating them for that. If high blood pressure, those there are other chronic medical illnesses. And then if a lot of time they come to me and they say, "Look, I went to the health food store. This is immune booster. Can I take it?" I look at it, take it. Okay. And then they come back and say, "Yeah, I took it and I didn't feel bad." So then go ahead and take it. I just wasn't trained in immune boosters like that, but I look it up. And again, there's a lot of things. For example, apple cider vinegar. I never even heard of that. Everybody keeps saying it's your grandmother's recipe and all this other stuff. But that stuff works. Okay. So we have to do a combination of traditional and what I call is alternative. And just because I wasn't trained in alternative doesn't mean it doesn't work.
you are like going in so many amazing directions. You like stopped here at racism. My mouth dropped because you just jumped right in. If we're going to talk about the elephant in the room, absolutely, because of those disparities. That was our last episode, speaking on health disparities and health inequities in women living with HIV, and just it really saddens me, especially because I am a black woman and I have experienced most of what I have read in
Hmm.
books and in data. And it's like, yo, it's really
Hmm.
hard. And then to get to the point where you just, as a provider, you just address like other therapies and not suggested them, but you spoke about them, other therapies, alternative ways of treat. I've never been to a provider who would have entertained that idea. Like,
Hmm.
never. Just to
Well,
hear.
it's I'm telling you, it's a partnership. So patients have taught me, okay, and that's why I say the most important um, quality I think a physician can have is to listen to the entire patient. And again, I just am really, really passionate about, as a physician, I have a voice that I can be an advocate for these healthcare disparities because I'm sick and tired of the ones in HIV. We already know we 12% of the population we account for over 42% of the HIV cases. And then we're least likely to be on medicines, least likely to find a place to be linked to care, and then we're more likely to die. That's just HIV. Okay, so we're not even talking about health or heart disease. And even COVID, all of them showed us that we have these diversities. I mean, these divisions, and these divisions in healthcare disparities are due to the racism. And there's one statistic I thought that was really, it was coming to me, is that if you were a white person, and wait, I want to be able to read this. Wait a minute. Um, that every 7 minutes a black person dies prematurely. And they say, put it another way, is if 200 black people die every day who wouldn't die if the health of black and white people were equal. That's already telling me it's racism. And then to say it another way that's different, and this is from Dr. Williams, David Williams. He says that if you are a black person in the United States with a disease, chances are you are receiving worse care than if you were similarly insured, similarly paid, similarly educated, and similarly sick white person. So all of that, I'm like, how in the world can I, you practice in a world that's like this. So when the patient comes to me, I have too much empathy. I'm like, oh my God, okay, this is happening. Oh, and so I think you have to listen and be empathetic. And so this is not about me, okay? What I want to be able to do is empower the readers to make their doctors listen to them and be empathetic. And if they can't do that, or then it's time for them to see another physician.
I love all of that. I can think of a time at the beginning of my diagnosis, maybe about like within the first 5 years, I took myself off of medication and did not
Mhm.
feel safe enough to go back and say anything to my provider because I felt like I would be judged. I felt like, you know, that if I'm not doing what you telling me I need to do, then you're not there for me anymore. Like, so I just felt like I had to keep that secret. So I fell out of care. It wasn't that I stopped
Wow.
taking
Uh-huh.
medication and that was all. I just stopped going to the doctor, and
Mhm.
that happens to many of us. And if we did have, providers in place or that we've been connected with where we felt safer, then maybe like that makes me, I wanted to come be one of your patients just then. Like, I need to watch them. Yes, like, not that I need to be watched like a baby or anything, but it is tailored to what I'm going through, what my
Mhm.
experience is. There is no one size fits all
Right.
in this.
And it says, I can't read that comment real quick. It says a doubt. And then it says, won't taking off the medicines multiply the virus? Yes, it will. Here in India, taking off medicines are considered only when a patient is undergoing surgery or has to be on ART all the time. This is something different I'm hearing, would like to know more in detail. As I said, that is absolutely correct. However, if I'm all for having a patient be undetectable, okay? But if they cannot become undetectable, or their quality of life is such that taking the medicines makes them unable to do what they would normally do, then they have to come off of the medicine. And
That
they do
happened
it
with me.
anyway. That's the thing. Okay. So I'm just saying, if you're off of the medicines, I have to follow you more. It means that I may not be able to see you once a month. I may have to see you once a week. I may have to see how you're doing. Are you complaining of a headache? Are you complaining of a cough? You may have to get more antibiotics or other treatments. That's not the way. What I'm saying is, I don't want everybody to go and say, my quality of life is is poor on these medicines. Dr. Mack said I could come off. No, it's a partnership, and you have to talk with that person. And the best that we know so far is that if you are undetectable, you're not going to pass it on to anyone. You're not going to seed your other organs, and you're going to feel better. But because a lot of these medicines weren't, women or other people um, of color weren't in it, we don't know how it acts. And so, therefore, I look at a person who cannot tolerate it at all as well. Let's sit down, let's have your quality of life. Okay. What is important? If you don't mind having diarrhea every day and vomiting every day, and that's what you're saying you're going through, and staying on the medicines, okay. But if you tell me your quality of life is such that it's unbearable, and actually, Dr. Mack, I stopped it, then I'm watching you. And it a lot of times, back more so when I was um, first starting out in HIV medicine, mothers would not disclose to their children. And they were the last ones to take care of their own self. Everybody else was taking care, they were taken care of. And they wouldn't disclose. And I would say to them, gosh, if they only knew that you had HIV and can do all of these things, you would be able to fight the stigma. You are what I need to fight the stigma. But the stigma was out there, and I'm not saying anything, but I saw what they could do. So if they can't do that on medication, that might not be for them. And I was telling Cece once before that I had a group of patients that didn't want to be on medicines, and the guidelines were saying, and at that time it was even like, if your viral load is 25,000 or you want to get it to, that's when you can start them on medicines. And these were the guidelines. And so I would tell the patients, this is the guidelines, and they say, no, I saw people on AZT and they died, and I don't want to be on this, and when I take it, it's too much. And again, for that particular AZT, it was true. Okay, the dose was so high, and people were having side effects, and it really wasn't helping the disease. And so I listened to people. Wait a minute, we have an opportunity to give them a chance to relate, and government that provide. The only business they have with you is to take your meds. Wait, I didn't hear the last one. And that's all. Any other thing is not their business. Okay, but you have to um, you're going to have to make them. Okay, um, that's to address
I was
racism.
just talking. I'm sorry. I was talking and the mic was off. I was saying that I think there's so much of what's coming up in the comment section right now is cultural as well. They're, the different, not to say that those things
Mm-hmm.
don't experience, we don't experience them here, but Joe is speaking from her experience in India. She says that it's more of a class divide than racism. If a person is
Okay.
from below the poverty line, he doesn't have that privilege. Just like how you mentioned about Black people. Similarly, there are statistics which shows more
Mm-hmm.
death in poor than in rich. Hence, HIV treatment, as I see, are a luxury available only for the privileged. Sad state of affairs. Absolutely. And then Bose's comment, I think is Nigeria,
Mm-hmm.
a part of Africa. I know. Please help me in the comments, Bose. I don't want to get it wrong, but we do have the opportunity or even given that chance to relate with our provider, especially in the government hospitals that provide HIV treatment services. The only business they have with you is just take your meds, and that's all. Anything else is not their business. And it's all because you have more than 20 patients to a doctor. Yeah.
Okay, but that is, but what I'm trying to get you to see is that you may have to educate the doctor in that particular hospital and just say, um, can we do it this way? And there are some other things you may have to make them aware of the social determinants or drivers of your particular health. And yes, I do practice in the United States. But there are some things that I really think I'm in a different country. And so you have to look at the whole person. And I think what Indian the person from India said was, it's is it a luxury to take the medicine and it's only for the rich? Um, and if you don't take it, I'm not sure if she's saying that the rich only take the medicine, so we're taking it. That was her comment.
I think she'll clarify
Okay.
in the comments. So these are two of our community advisory board members that you're talking to. So there's
Good.
Joe and
Good.
Bose.
Uh-huh.
And then we had more input from our other members, some questions that they also wanted to pose to you.
Uh-huh.
Um, and I think that Bose's last comment kind of goes into this. So there are more than 20 patients to a doctor. So then somebody else wants to know, how do you get the provider to read the charts before they come into the room?
Yeah, I mean, that's huge. Okay, I don't know how to get them to read it other than to tell them when you leave that for the next time, can you just go over so I don't have to, reiterate, or we can do more. Let them know that that's not pleasing to you.
It's
And also,
re-traumatizing, actually, like having to go back and talk about when was you diagnosed or what
yeah,
medication you've been on.
it,
Like I've
it
been repeating the same story for the last
that
14
and
years.
it takes too much time, and then again that makes the partnership go further and further away. Okay, so I would just tell them point blank, can you just review my chart for the next time, and next time we come in I want to discuss some other things. And I think if you're international, I think the Well Project has lots of articles that even if you printed them or pulled them up, and just showed them, this is what I want to talk about next time, or can you tell me how this is. um, the days of having just a doctor come in, um, look at your labs, give you your medicines, tell you this is what you take, I'm only interested in that. I'm only interested in your side effects. This is a disease that affects the entire body, the whole body. So you've got to be willing to listen to the other things, and other things that affect that. Um, do you have housing? Do you have water? Do you have clean water? Do you have food? How do you get to these appointments? What's the transportation like? Um, do I need to? Would you have more time with me if we had a telehealth or a video or a telephone? Well, if that's the case, I don't need to see your face. Call me on the phone and let us talk. You,
Oh my gosh, that
you see
makes
what
such a difference.
it
With having to work when you're working hourly, and now I'm having to take time off from work to make it to the doctor's office. I've missed, a days of pay, and I can't afford it. I can't afford it because my rent is dependent on it. My kids are dependent on it. And this is because I'm living with a diagnosis such as HIV. And then,
Mhm,
could take you back to beating yourself up again. Like if I
mhm,
wasn't living with HIV, then I wouldn't have to come to these appointments
mhm.
and just if there were some compassion from the other end that kind of could help curtail that before it even happened. Um, when you're talking about this, I'm just thinking of one of my last
Excuse me for
experience.
a minute. Let me
Problems.
go on over
So
here.
I'll keep talking to you.
Okay, go ahead.
Okay.
Mhm.
So one of my last experiences at the provider, I'm trying to find a new provider, one that is closest to where I live. And first, when I made the appointment, it just didn't feel right. Because I called, she's like, "What? I said, I need to make an appointment." She said, "What type of appointment?" I said, "Medical appointment." "What type of medical appointment?" So I have to say HIV appointment. And it just made me feel funny, not for myself, because everybody in my circle knows, but for that
Right.
one person that calls and is not able to be so open. So I mentioned it when I got there, and the lady's talking about, well, it's not up to me. Maybe you need to wait until you're in a safer space to make that phone call. We can't determine, your environment when you call. So there's front desk staff at a new
Mhm,
provider.
mhm,
Then I get in because it's a new provider. I have to do a new intake. So now I am in the provider's office for 3 hours that day for them to pull all my labs all over again, send me out of the office with a medication I've never taken in my life. And I don't know a lot. I just know that if it's seven of us standing in the room, I'm usually not on the same medication as the majority. For
mhm.
some reason, like I had a resistance when I got diagnosed. So he put me on a medication or tried to that a lot of people take. And it just didn't feel right. like it,
Mhm,
and he wasn't hearing me. He's like, no, no, it's fine. And he did take time to read the drug chart, and everything. But those words I don't understand. I don't
mhm,
know what any
mhm,
of this means.
mhm.
But he did take that time. But I still left not feeling like I knew more. Like I didn't feel confident in anything that he told me. So I did not take the medication, and I went back to a place where I felt safer.
Okay.
Not necessarily, the quality of care, but I felt safer, like somebody was going to listen to me. I'd much rather go through that than, just having a provider push on me what they feel like I'm supposed to.
Mhm, mhm. And it's so true. It's the entire office from front desk to nurses to um, your medical office assistants. They represent us. So you have to be really careful. And when you did the right thing because you left, because you actually seemed like you was trying to talk to him and tell him, and it wasn't a connect. Okay. um then yes, there are places that people will understand you, and that's what you have to do, and you don't settle for less. You It's your body. You got to make people um respect you, and teach. You're going to teach them about the disease because you have it. Okay. And so they have book knowledge, but you're going to have to teach them, and that's why I say it's a partnership. um, and slowing down to listen to the patients when hectic. Somebody said 20 patients. I think they mean 20 patients in a day. Yeah, that's a lot of patients for um, this complex disease. When I first started out, we used to see 3 patients in the morning, 3 patients in the evening. That was a luxury. You could do everything. But now you're seeing 10 in the morning, 10 in the evening. You still got to slow down because that patient does not care who's coming behind them. They want you to address what their concerns are. And that's what you have to do. That's how I feel teaching every time I need to order refill. I don't know what that means. Um,
So I don't know. I'll try to speak from
Teaching
how I
every time I
interpreted it.
need to order a refill. I don't know. Yeah, ask them what they mean. Um, uh,
Aaron, could you elaborate a little bit? But I'm thinking, like, when I go into the provider's office, sometimes everyone in the office isn't knowledgeable. So, like, hey, can you just refill my medicine? And then you have to go through this whole thing yo, I know what I'm doing. I just need this medication. Can you
mhm,
just, and I'm sure there are probably some procedures that I don't know about, but it just feels so frustrating
mhm.
sometimes. Sorry, Joe.
Yeah, no, no,
Teaching the
no.
rep,
And
taking
those
no
that
order.
frustration, Cece, you take to when you go in with your doctor to say that, when I ask for a refill, I teaching the rep to take the order. What? Teaching the rep.
That's what
Oh,
she.
is that what she's saying? The same thing that you're saying? Okay. So when again, when you're asking for a refill, and then the person that you're asking, it usually should be a nurse. But if it's at a place where it's not a designated HIV center, um, or Oh, thank you, Olivia. Okay. There's not a designated HIV center. You may you may have to educate the doctor to say, when we call for these prescriptions, how do we do it? And Olivia, can you put up the comment again? Yeah. Okay. So when you're teaching the, you're saying that when you order, I just want to get this correct. You need a medication, you call in to the doctor's office, and you're having to teach them what, because they should know what you're on. And if you're at a place that does other things other than HIV, you don't want them talking about your medications or anything. That should be in a more secure place so that no one is listening. Can you ask Olivia to put up her comment again, because she said it was something.
So I'm going to read all of Aaron's all together.
Okay.
All of Aaron's together goes, "That's how I feel, teaching every time I need to order a refill. Teaching the rep taking the order." And then further clarification was to the pharmacy. So, I mean, can you see that disconnect there though? Like the pharmacy isn't always as knowledgeable about HIV specifically. So I'm not sure why that clarification would need to happen then. Or I've had it happen where like, yo, this medication is really, really important. Like I really, really need this. It can't just be like that. I've had to do that. And I know that that is extremely frustrating.
Mhm. I
Um,
Yeah, I'm not sure. Um, but when when you get down to a week of your last pills, that's when you want to put them in. Not that it's the last day and trying to explain to somebody why it's so important. Okay. And maybe they can give more than 1 month. Um, so because that, if you've got 20 people on a day and all 20 of them say that, or calling in and saying, I need my medicine today because I'm on my last pill. Okay. You will do it, but you may not get to it in a timely fashion.
mhm.
So I think to improve patient provider communication, your medications, you shouldn't be having to educate the doctor, shouldn't be having to educate the nurse. But if you are, you're going to do it for the one time so that the next time they've listened to you and you can get your medicines on time. Um,
Absolutely. I want to move on to Heather's comment because this is really good. Really, really
okay.
good. There's so much to say about language justice. I'm sorry. Where did it go? There it goes. There's so much to say about the
Oh, put that back up.
importance of language justice when having patient provider conversations as well. The difference between the use of the word infected rather than living with HIV can completely destroy a safe space to talk about quality of life and treatment issues. Yes.
I agree with that, and that is why, um, just because I went to medical school, or just because doctors went to medical school, that was the terminology, and so you have to change and update yourself. Okay. So why should we say that they're infected? You're living with a disease. I don't say I'm infected with diabetes or I'm infected with high blood pressure. You have that. So, yes, the language is very, very important. And we are changing it. And I can really say with Well Project and other HIV specific organizations, they make that determination that no, we don't say this anymore, or this is a person with this. And you have to be very mindful of that. And so either everybody who is almost like if everybody teaches or sees HIV patients, they ought to be able to access the Well Project's
Mhm.
articles so you can see what's going on, or you join um, HIV MA, which is HIV Medical Association, or the Academy of HIV Medicine, which does the education. And that's in the States. I don't know about um, international, but I know that in those two organizations, you can still join.
Thank you for that. I think that we may have addressed this a little bit, but what have you noticed that's different in working with people living with HIV versus other chronic illnesses?
Nothing, nothing. It's just a different illness. Okay. Um, the only other thing I can say that is different, I feel that people who are living with HIV are much stronger and take more of an interest in their particular disease, and they're more active or advocates. So I have more people or patients that I do things with on the advocacy side than I do for a diabetic patient.
Mhm.
And the issues are the same. There may be new medications that come out that would be better, and then they're angry. The diabetic is angry, or I should say the person living with diabetes is angry that they don't have this. And I would say a lot of times, well, you should be like people who live with HIV, you got to advocate. And um, it just, I think that's really the difference. There is, to me, and since I see both, that I don't see a difference. Maybe in the past, I might have said that a person living with HIV was depressed more, but that's not true anymore. Life expectancy is better. You know, there used to be a look that if you had HIV, that's not true anymore. And actually, I'm finding more depression in people who are not living with HIV. And the people who are living with HIV are able to get the support that they need. At least I would say in the United States, it's more available. You might have to navigate a little bit, but I think we do try to adjust that. I don't see a difference in my
Dr.
patients.
Celeste Watkins Hayes, she talks about that when you say the support of for people living with HIV. She calls it the HIV safety net. And I have
Who
never
does this? I'm sorry.
Dr. Celeste Watkins Hayes, she's a
Okay.
sociologist of some sort.
Okay.
I've spoken with her a few times, but the 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 safety net that many people living with HIV are able to develop or create, just based merely because of living with HIV. So
Hmm.
I can say that my net is composed of, my friends, other advocates, my family, um, my work family, and those things are what makes it so much easier for me to go in and advocate. I know that I have, resources behind me that I'm going and not just speaking up for myself, but I'm making it, the next person that comes behind me visit hopefully easier because someone has,
Okay.
brought these things up and made a big deal sometimes about it. The breastfeeding one where I really had to advocate for myself, and they're supposed to be holding a training at this facility at the end of the year, like a grand
Okay.
round, which I think
Hmm.
is really exciting. But that just came based off of, you know, the provider not necessarily hearing my wants and desires and trying to push me into a certain decision, and me not agreeing with it and coming back and following it up on it. I'm not sure if many people know, but you know, of the grievance process, I've done it the wrong way and I've done it the right way before
Mhm.
when I've been unhappy with the care I've received at places. So just doing it the right way this time, I actually got people that listened to what my complaint was and they were able to come up with a plan to respond to make sure, you know, that my voice was being heard and that some changes were made. Now, I will always encourage people to do the same in their own lives. It can be hard though. Those white coats are really intimidating. Okay?
Mhm. Okay.
She
I
said,
I agree. I agree. Um, and and so much so, it's not just intimidating um, for you, but sometimes it's intimidating for the patients. Even they come in and take your blood pressure, here they come as sky high, and they say, "Is that white coat?" And then you sit down and you talk and you have a conversation and you do the blood pressure at the end. And there's even some talk of um, people not wearing white coats. Okay, and so I think it's a partnership. I wear scrubs. Okay, I
really?
may or may not wear a white coat if I know that the white coat is going to offset somebody, but you know, yeah, it can be intimidating, but you look at the person in the white coat and you don't want that person to be intimidating um, to you.
I one of the best visits that I had to a provider, what they provided, it was for my child, and we saw a Hispanic male doctor.
Uh-huh.
And my son had a rash, and the doctor like Googled photos of what the rash could have been and sent them to me. But in his Google search, he put brown skin behind the rash. I'm like, yo,
Yeah, yes, yes,
but
yes.
oh my goodness, that made like it just made me feel seen. It made me feel like he understood. It made me feel
Hmm.
like we could be on a couple that we could have been on to something. Like it was great. We
Yeah,
have some
no,
questions coming through though, so
yeah, that's so important that you have to know the culture that you're in, and do why would put up something that doesn't represent and so that's good. What are some of the questions?
okay. Are they should be popping up on the screen. Oh, what is a reasonable amount of time to wait for my blood to be drawn?
Do you mean in the office at that particular time, or I'll answer them both. Our guidelines are changing as to how often you should have blood drawn. So if you're undetectable, um, you can go 3, 6, or 9 months, depending on all the others. But this question, I think, is saying a reasonable time to wait for my blood to be drawn at the office, and it might be after the visit. Is that right, Aaron? So you see a doctor and you're waiting more than an hour or two to have blood drawn? Or is she asking if I'm undetectable or not undetectable, how long do I have to wait for blood tests?
I'm not sure. That
Okay.
question was a
Because
lot further.
the guidelines do change. And if I have a patient that's been undetectable for years, I might just do it every every 6 months. And then I have patients who I'm doing it, once a month, and then I'm doing it also a quarter. So I think it just depends. Um, However, I don't think you need to be spending all day in the doctor's office. But then again, this is international, so I don't want to be stepping on another country's toes and saying
I've done it
maybe
right
that
here in
didn't.
America though. Right
Okay.
here in America, I done had to sit in the doctor's office all day. Like I ain't
Yeah,
got nothing to do.
Yeah,
Like,
I
no,
know. Yeah, I mean, you have to be respectful, I think, both ways of people's time. Okay. Um, I know I have three kids, and I had a gynecologist that every time I went, it was a 4 hour wait. But the
wait.
gynecologist was just a 4 hour wait. If my appointment was at 1 o'clock, I knew I wasn't going to get in until 4 or 5. Okay.
Wow.
And I had trained under this particular gynecologist, so I really thought he was all that. But I did speak up. I said, "Look, you got to do something. I know you. There are other people in here that can do what you do. We all kind of like you, but something has to be done." And so, what his solution was, which I thought was good after so many of us spoke up, he would call us and say, "Your appointment's for 1, but really I'm far behind. Please don't come in until such and such." And sometimes it would be closer to 5 o'clock. I appreciated that.
Mhm,
Um,
mhm.
and but I always would be angry, and I was a physician. How dare you think I'm going to take off at 1 for an appointment, and then you don't see me till 5? And I think at one point, he got the message because I was pregnant. And I was waiting 4 hours, and then when I came in, and my blood pressure was through the roof, and they were like, "Oh my gosh, what happened? What happened? What did she do?" And so he came up with a solution for that for the pregnant people. But then when you weren't pregnant, it was okay. We will call you. Do not come in. We'll call you. White coat did elevate. They hooked me up and left the room. And okay, all right, okay.
It's
I like
serious.
that
Like,
one. Okay,
you
excellent.
know, and then different dynamics of it all. Being diagnosed in the South, in the rural South,
Oh,
I always have to make that distinction. A white man walking into the room with a white coat on, like I just felt like I had no voice. Like,
oh, oh.
so navigating my healthcare in a way now that, like, oh, I can actually say stuff is so new for me. So, this is what I was going to ask. What do you believe is the best method to be when introducing HIV education and stigma reduction to non STD, STI facilities? Some of us see our other doctors more than we do our HIV docs.
And what's the question, Cece?
So she specifically was asking, what do you believe is the best method to be when introducing HIV education and stigma reduction to non STD facilities?
What's the best way?
Yes. The best method to give them the information. So I can't think of what examples like she would have been thinking of, but is it like brochures? Is it like trainings? How do we get our other providers caught up with where many of our HIV providers may be?
Okay, all right. So, um, okay, it may take a little bit of work, but this is where your advocacy comes in. You may have to write a letter, talk to the administrator, talk to the chief medical director, and say, "We're all coming here, and we noticed that this is an issue. How can we, work on so that it changes?" It may be you have to be the person to do it. Um, and sometimes I've noticed that when you do things like this, it's sometimes better to do it in a group that has the same type of focus, so that it's not just one person. But if you're not privy to that, then you have to be that one person. And I think um, the best way is expressing how you feel, so that each time you go there, that it's not an issue. And if you're going to more than one place, you would have to do the same thing.
Thank you. Thank you. We're getting all these questions answered. I don't think we many of us don't have access to a provider like this to just be able to shoot questions to. So thank you. Um, Joe's question, I think this is the one that she once highlighted. So she says, clarification: in India, government hospitals do give free medicines, but there are cases of stockouts. At times, patients go without medicines, which can take a month or two. But for the rich, they easily get medicines as they pay for it, no matter how expensive it is. Hence, they don't suffer stockouts, which might result in drug resistance. This, okay, this, Olivia Ford, that's what I meant to say when I mentioned that art is a luxury and a privilege for the rich.
Okay. I
Okay, understand
I
that.
agree with that, and I think that that's a true statement. Um, is there some type of advocacy that has to be done there? But this is where we come into equity, okay? That e- we have to have resources so that everyone can get the treatment that they need. And yes, I do agree that India has the generics, and they were the ones that kind of told us that when we were first starting, we didn't realize as the provider that the medications were so expensive, and that was the limiting factor. And then India came out with these generics. We're like, what? And so, yeah, that's terrible. Okay, that we that's not equitable. Okay, and so yeah, we have to. I'm not saying I'm the expert. I'm just saying I that we have to have equity, and it may just be each one teach one or each one do one. Um, but that's sad that if you have money, you're getting better care.
Yes, yes. It's very sad. People right here in this country, I'm in a group where many of the women are located down south, and sometimes they do not have medication. Like,
Mhm.
wow. And I've experienced that myself, but I've been back here for so long that I can't even fathom not having access to the medications that I need to continue to live my life and the way that I've been
Mhm.
living. It, it's disheartening. Um, let's see, we done talked about so much. Let's see. How can we get providers to listen without assumption and hear us in regards to new information about our diagnosis, like PrEP and breastfeed and U equals U? They can't gatekeep. And at this point, they have to tell patients the truth. And with this, they will give the patient ease as they won't suffer thinking they will pass HIV to their partner and will motivate them to have adherence.
Okay. So again, um, how do you get I think the question is how do you get providers to be up to date um,
I heard that too.
on information? So again, if you went somewhere and that wasn't the case, then you tell them the next time I come or to the next patient, um, this is what you need to do. Okay, I think people are sometimes scared to say to a doctor or to tell them how dissatisfied they are, but I think that that's how we have to do. If they're not going to um, provide the respect to me of learning about my disease or trying to help me understand all of warning signs that something may be amiss, and when I seek medical treatment or I feel that they don't care, then you tell them, give them a chance to um, change. Um, and
I
again,
tried
all
it.
of this it boils down to the importance of patient communication. Um, even just you have to, let me see, you have to be able to speak up and sometimes teach the person that they have a bias that they may not have known that they had. And so that may be a way to get them to address all of your concerns and to look at you differently so that when the next person comes in, I got to address all of their concerns.
Okay, we're coming up to the end. I think this probably will be one of our last comments, last two. So we have this one that says, these people in Senate and Congress tell me that health is a privilege. No, it's a human right. I absolutely agree.
I agree with that.
And Aaron here. Aaron had me tripping out. So they say, I believe in helping prevent HIV with PrEP, but when people get free PrEP and my private insurance copays are more than I'm more discouraged and bitter, honestly. Give pills to people who don't even have it over giving it to people that are living with it. I used to be on trials in the 90s, so I feel like I should get a lifetime supply for free.
Yeah, I kind of agree with you. Yes, that
That's foul.
that is true. And why should it be so expensive that you can't? It comes down to health equity, okay? And I think I agree with you. I'm sorry. That I definitely agree with you. Um, and we see it here also, where if we're trying to write for PrEP, uh, if their insurance doesn't cover it, it's really so expensive. And I'm trying to prevent it um, in this community, but if I can't, they don't have the resources. And I think I see it more with PEP because I'm always telling them how you do it. And you come here with PEP, and then I write the prescription, and they come in, that's $1,000, Dr. Mack. And then I'm like, run to this emergency room.
Mhm.
You
Yeah.
kind of have to know, okay, yeah, go to this. Because by the time I get on the phone, try to talk to, a farmer to give me a coupon so they can get it, just go to somewhere that already has a grant. But that's not, you want to end the epidemic and you make it difficult for people who have a job. You trying to tell me that people shouldn't have a job so they can get medicines? How backwards is that? So
When we
it's
talk
a lot
about
of things.
quality of life,
Yes,
quality.
I always go back to the quality of life. That's what's so important to me.
So you have definitely even displayed through our conversation today your patience, your intensive listening and all of it. Like I would feel so honored to be able to have a provider who operates in the way that you've shown today. Um,
Well,
this is the end of this episode. I thank
thank you.
everyone so much for being here with us today. Join us next month for our next episode that's going to be 23, I think. And just keep an eye out for what that topic is going to be. Once again, thank you for joining us, and I hope you all have a good day.
And thank you for having me.
You're welcome.